Welcome everyone. My name is Merle Cunningham with the Department of Health Policy. I've been the convener coordinator of the series this year. I'm delighted to welcome everyone. This is the sixth and final for this academic year. We'll have a full session coming up the next year for the next academic year with quite a few intriguing and interesting people that have already agreed to come in from different parts of the country. Now that we've developed our Skype technology through the internet, it's possible to have a fairly useful and productive interaction with somebody who's not on campus, so that's great. So Anne has been affiliated with the university for quite a while. Her bio is in the material that we sent out, and we're delighted to have her with us today to talk about the workforce roles and issues around the patient navigator function in the field of cancer treatment. It's here. Anne? Can you see it stuck in there? Mistake with the silk tie.
So I know some of you have been anxiously awaiting this talk. It got rescheduled because of snow, so I appreciate your patience. So I'm Ann Willis. I'm with the George Washington University Cancer Institute, and today I'm going to talk about a project that we've been working on related to patient navigation role delineation. And specifically, I will talk about the background and history of patient navigation, specifically in oncology. I'll discuss some key challenges for the profession, and then I will describe a collaborative initiative that we're working on to develop a competency-based training for oncology patient navigators. So if you're not familiar with the Cancer Institute, we live in the School of Medicine and Health Sciences here at the George Washington University. We work with about 80 faculty across 7 different schools to ensure access to quality patient-centered care across the cancer continuum through community engagement, patient and family empowerment, healthcare professional education, policy advocacy, and collaborative multidisciplinary research. And through the Cancer Institute, we also have the Center for the Advancement of Cancer Survivorship, Navigation, and Policy. And we call this CA-SNAP. And through CA-SNAP, we provide resources related to navigation and survivorship. We have a monthly e-news that goes out. We also have a free webinar series that we do monthly. We work on health policy initiatives, including writing policy reports and white papers. We do education and training for a variety of healthcare professionals, and then we also conduct research. So a lot of what I'm talking about today is what we've done through CA-SNAP. So I'm not sure how much everybody here knows about oncology patient navigation, so I wanted to briefly start off with the history. So Dr. Harold P. Freeman is a surgeon from Harlem, and he introduced in 1990 an intervention that he thought of to help reduce cancer health disparities among the poor in Harlem, New York. And so he was realizing that the patients that were coming in to see him were presenting at a later stage and they were dying sooner than his other patients. And so he thought about why this was happening and recognized that there were significant barriers to care for this population. So he created this intervention, patient navigation, to assist patients through screening, diagnosis, and treatment of cancer. And the original intervention was very similar to what you can think of for community health workers. So these were people who would go out into the community and help with issues like transportation, help to reduce fear and stigma, and to really help get people into the healthcare system. So he did a study, and you can see the results on this slide. Before the patient navigation intervention, the 5-year survival rates were about 39%. And you can see a pretty significant increase after patient navigation to about 70% for the 5-year survival. So since that time, so that was in 1990 when he invented the concept of patient navigation, has expanded across the cancer continuum. So a lot of the work he was doing was getting people in to be screened earlier. Now we have patient navigators across the continuum, which I'll talk about more in a second. And it includes not only patients, but families and caregivers as well. It's been replicated across the country in various diseases, for example, diabetes, heart disease, and HIV/AIDS. And the National Cancer Institute funded what they called their Patient Navigation Research Program. And so this program funded 9 sites across the country. GW was one of those sites, and they have studied impact on timeliness, patient satisfaction, and cost effectiveness. So a lot of the results from that study are just now coming out or have started to come out in the last couple of years. And then a big driver for patient navigation is the new Commission on Cancer standard. So the Commission on Cancer is a body that accredits cancer programs across the country. And they actually, the accredited programs actually provide care for about 71% of newly diagnosed patients. So the Commission on Cancer therefore reaches a pretty significant number of patients. And a couple of years ago, they announced their new standards starting in 2015. And one of those standards includes that institutions must have a process for patient navigation, and they must do a community needs assessment. So they're intentionally vague. They aren't mandating that every cancer program has a patient navigation program on site because, and we'll talk a little bit more about some of these challenges, but every program is different. Every cancer program sees a different patient mix. They have different resources. But this is a huge driving factor in terms of increasing the number of patient navigation programs that are occurring around the country. So why is patient navigation needed? I don't think I need to tell anybody in this room, but the healthcare system is fragmented and complex. In cancer, it's especially complex. If you have people who are having surgery, radiation, and treatment, those are completely different types of treatment that can be in different facilities. Here in DC, those treatments can be at different facilities that are in very different locations. There might not be good communication across those facilities. There's a need to address health disparities and improve quality of life for those affected by cancer. And this is true across the continuum in terms of other diseases, but the health disparities are especially prevalent in cancer. And then within cancer, because the treatments are difficult, they can last a long time, it's especially important to identify and eliminate barriers to care. And you'll see this barriers to care throughout the presentation. But it's also a culturally competent intervention that is based upon a specific population's needs. So with that background, I wanted to just use the definition that I'll be using throughout the presentation. So patient navigation is an intervention that addresses barriers to quality standard care by providing individualized assistance to patients, survivors, and families. And we'll walk through some of what these are specifically. So these are just kind of from a high level, some of the things that patient navigators do. So the main thing that I mentioned is reduce barriers. So there are all kinds of barriers. In DC, transportation can be a big barrier. In some of our more underserved wards, there are no cancer programs there, so they have to travel, and it's not always easy to get places by the bus or by the metro. We have lots of patients that have to take 2 buses to get to the metro and then maybe have to take a cab to get where they're going. Patient navigators also educate patients. They also can educate providers about what patients' needs and preferences are. They can build partnerships in the community, and I'll talk a little bit more about this on one of my next slides. They can help coordinate appointments, and I don't mean scheduling, I really mean helping with the care coordination, especially in cancer if you're having different types of treatments in different places. Patient navigators can play a pretty significant role with that. They can also help to maintain communication, and it's both communicating with the patient, but also helping to communicate the patient's needs and preferences to the healthcare team. So they play a pretty significant role as this communication liaison. They also are important for arranging for and connecting with support. So these things could be psychosocial support services, they could be practical support, so connecting them with information on employment issues. Another key role is that navigators help to teach self-advocacy. They help to teach patients how they can communicate, how they can make decisions, how they can be more involved in their healthcare and help to really make those important decisions. And I think another key role of navigators that's worth pointing out is that they can also help to increase clinical trial awareness so we can have more people participating. And adults in oncology, very few actually participate in clinical trials. So this is a potentially significant role that they can help to play to get people enrolled. So just to give you an example, here in our program at GW, we have two navigators that are in the phase of the sort of diagnostic and diagnosis. So we have a nurse navigator who provides education before and after biopsy and helps to follow up with patients. We have another patient navigator who's funded by the Avon Foundation who provides support. She helps to ensure access to care, which is a really important part of what she does. So she works a lot on insurance and referral issues. She helps with translation services, she helps to explain testing, and she helps to connect patients to resources. So things like transportation or counseling or other services. So then in the treatment phase, we have two navigators. One is in the breast care center, and so she provides resources and support for all breast cancer patients that are undergoing surgery. And then we also have another one who is in radiation oncology, and she's funded by a partnership between the Cancer Institute and the American Cancer Society, and she provides navigation to patients receiving radiation treatment. And then at the end of the continuum, we also have a survivorship navigator who is currently funded through Susan G. Komen. And so she helps to provide survivorship navigation services through our Thriving After Cancer program, which is a clinical survivorship program for people who were diagnosed as adults with cancer but have finished active treatment. And she helps to address barriers to care. She provides a lot of education on post-treatment issues. If you're not super familiar with cancer, once people end treatment, they still need to be followed up, and oftentimes the healthcare system just says, okay, go home, figure it out, and people don't realize that they are at risk for all kinds of medical and psychosocial and practical problems. So it's especially important that we have a navigator at this phase 2 to help make sure people transition to survivorship and have the resources that they need. So we also administer the DC Citywide Patient Navigation Network, which we call CPNN. And this is something that actually grew out of the Patient Navigation Research Program that I mentioned earlier that was funded by the National Cancer Institute. So that program was very research focused, and when that funding ran out, we wanted to continue the connection across the navigators. So we created CPNN with funding from the DC Cancer Consortium originally, and that was really focused on helping navigators network with each other, providing them training and resources, and we're still continuing that effort today, though it's currently no longer funded by the Cancer Consortium. But it includes a variety of institutions, so we have primary care sites, we have cancer centers, we have screening sites, and we have community-based organizations. So we have varieties from a lot of different backgrounds so that we can create this group of navigators that know each other. So if they have a patient that is going to another institution, they can go ahead and call that navigator and talk with them. So it helps to create some continuity for patients. And we've been collecting data for several years, and the main barriers that patients face and that patient navigators are helping with are related to social and practical support, a lot of financial issues, a lot of transportation issues, a lot of care fragmentation issues, and there are a lot of issues related to fear or negative perceptions of the healthcare system. So there are some challenges to patient navigation. So I mentioned that it kind of started in oncology in 1990, so it's a relatively new field. And these 4 challenge areas are all interrelated, and I'm going to briefly talk about them. But the main problem is lack of role clarity and standardization, and I'll get more into that. But there's also effectiveness and cost effectiveness issues, funding and sustainability issues, and it's important to keep in mind the role of the state as well. So through CA SNAP, we did a survey about a year ago, and we had about 73 patient navigators complete this question for the survey. And we didn't separate them out by different types of navigators, which I'll get to in a second, but the main things that people identified themselves as challenges are related to lack of reimbursement and lack of funding. So if you remember what I was just talking about in terms of our program, our navigators are funded through a variety of mechanisms. Oftentimes they're grant funded, which creates a sustainability challenge. And then the other big area is lack of role clarity. So navigators themselves are finding that this is a challenge as well. So one of the big problems is when we say patient navigator, people can sometimes are sometimes referring to community health workers. sometimes they're referring to what's been called lay, but what we call non-clinically licensed patient navigators. So they don't have a clinical license. They may or may not have a college degree or a master's degree. And then there's what we call the clinically licensed patient navigators. So you have nurse navigators and social work navigators. And people use or patient navigator to mean any one of these groups, which creates a huge challenge for the field. And there's no consistent terminology. If you have seen one patient navigation program, you have seen one patient navigation program, people use the same words and they're talking about completely different things. The term navigator, also in the Affordable Care Act, so we're seeing this term thrown around a lot, but people aren't specific about the way that they're using it. There's a lot of problems with navigators doing administrative work because people don't understand what they do. So something our navigators deal with, and we've heard from the community that that's a big problem. On the flip side of that, there's also a challenge of navigators being given clinical tasks that they legally shouldn't be doing. They're not clinically licensed to do. So there's some huge challenges, and it's because there's no consistency. There's no job description that exists. There's no agreement on what navigators should be doing. On top of all of that, just to add to the challenges, navigators are focused on different parts of the continuum. So the way I described our program, we have them in screening, treatment, and survivorship. And so it's difficult to come up with a common set of job responsibilities when they're doing very different things in these different parts of the continuum. And some navigators work across the entire continuum. And so it's difficult to create common measures. So even though there are some studies, it's hard to actually compare them to each other because they're using very different measures. And one of the big things that we've identified is that there's no established competencies. So anyone in this room today could call yourself a patient navigator and go out and get a job as a patient navigator. And there's no credentialing process. There's nothing to say that this navigator has the same background and training as this navigator. So there are training programs, but those programs haven't coordinated, and there's not a common set of competencies. So in terms of effectiveness and yes.
Do you take questions at the end?
We'll take questions at the end.
Okay.
We're recording it.
Don't forget. So in terms of effectiveness and cost effectiveness, patient navigation has shown some evidence of benefit, especially on the screening side. So patient navigators can help get people into screening and get people diagnosed more quickly than with outpatient navigators and help get them into treatment more quickly. But again, we don't have consistent measures, so people are measuring very different things in different ways. And the cost effectiveness of patient navigation has still not been established. And so if you go back to when I was talking about the new care standards from the Commission on Cancer, if they're saying you have to have some sort of patient navigation process, all of a sudden these cancer programs are saying, why am I doing this and how am I paying for it? And if there's no credentialing process and these people aren't getting reimbursed, it creates a huge problem. And for the institution, they're saying, well, why am I paying for this? I have no idea if it works. Why am I putting money into this program? So we did some research last year. We looked to see what we could find in terms of program costs for patient navigation programs. I'm not sure how clearly you can see this slide, but we looked into several different programs, and what this slide basically shows is that the cost of these programs, they typically include personnel costs, program costs, and sometimes procedure costs, like the cost of a mammogram. But the cost can really vary from up here. There's one that's $25,000 a year, and then there's one that's $317,000 per year. So these patient navigation programs are all completely different. The one that's more expensive than the other one, they have included a social worker and a program director. So the costs are really variable depending on the program, but they vary pretty widely across entities. So in our survey of navigators, we also asked them how they're funding their programs. And this is a question we hear a lot from people. How do I fund our patient navigation program? So the main way is through operational budget, meaning that the institution says, okay, we will give you a line item, here's your money. But a pretty significant number of programs are also being funded through grants. And this doesn't add up to 100 because they could pick more than one of these. So what's happening in many programs is that they get some operational budget, but then they also have to find grants for the rest of it. To a lesser extent, they're using existing resources to help pay for different parts of their program. And very few programs are able to get reimbursement. And there are nurse navigators, and there might be options for reimbursement for those groups, but for the non-clinically licensed navigators, there's not a reimbursement option. So given all of these challenges, we wanted to think about how we could best move the field forward. So we wanted to create a competency-based training, and that's what the rest of the slides will be focused on. So last year in September, we were awarded funding from the Centers for Disease Control and Prevention to provide technical assistance to state comprehensive cancer control programs. So every state receives funding to do cancer control activities, and those are pretty broadly defined. But through that funding mechanism, we're able to build out some online trainings. And so we want to build one that's competency-based for patient navigators, and we want it to be free so that anybody anywhere can access it. So historically, we've had several different training programs here. We have one, it's called our Executive Training on Navigation and Survivorship. It's a nuts and bolts approach to program development. So it covers things like, how do you do a needs assessment? How do you figure out what program components you want? How do you evaluate your program? And that one's really more for the people that are overseeing the program rather than the navigators themselves. But historically, we've had a knowledge-based training, and our goal is to translate that knowledge-based training into a competency-based training and develop a toolkit to go along with it, which I'll talk about in a minute. So there's been a shift in medical education from focusing on structure and process-based trainings, which are very focused on knowledge and knowledge acquisition, to ensuring that training is competency-based. So it's more about applying that knowledge and demonstrating the ability to do something. So we embarked on this effort about a year ago to help us develop a competency-based training. So these are the steps, and I'll walk through each of these. But we started with a literature review and an internet review. And I'll talk more about that one on the next slide. We developed a framework through expert consensus, and then we recently conducted focus groups with patient navigators. So you'll get some hot off the press findings from that. And then the next step is to create some competencies. And then we'll validate those competencies with patient navigators. And then we'll develop a training using the formula that's on the bottom of the slide. So we worked with several organizations on this project. It was very much a collaborative effort. So we've been working with the Academy of Oncology Nurse and Patient Navigators, the Oncology Nursing Society, the National Association of Social Workers, the Association of Oncology Social Workers, the Association of Community Cancer Centers, and we've also included several patient navigators and community health workers on the project. So we scoured the universe to try to find anything we could related to training, related to activities or roles or competencies for patient navigators, also including community health workers and including the clinically licensed navigators, so nurses and social workers. And we also found some existing community health worker competencies. The community health workers, and I'll come back to this too, they've done a good job of establishing the profession and finding ways for payment in several states for their work. And there is some overlap across these different groups. So we wanted to learn from the community health workers and from what they had done. So we took all of these activities and roles and tasks and anything that we found, and we aligned them with these 12 functional domains. And these domains emerged from what we found. So there's professional roles and responsibilities, communication, patient empowerment, cultural competency, ethics and professional conduct, education, prevention, and health promotion, psychosocial support services and assessment, barriers to care and health disparities, community resources, outreach, care coordination, and advocacy. So these are the things that emerged from looking across all of the different resources that we found. So we created this giant framework, and our first step was to come up with a definition for each functional area domain that captured the similarities across each of the three groups. So in this example, the domain is barriers to care or health disparities. So the definition we used that we think is common across these groups is identifying and addressing barriers to care and reducing health disparities, and then there's a definition of how health disparities are defined. And so what we wanted to do is not recreate the wheel. We didn't want to invent anything for other groups that had things that were established. We were just trying to separate out what does the community health worker do, and how is that different from the non-clinically licensed patient navigator, and how is that different from the clinically licensed patient navigator. So in this example, and again, this is based on what emerged from the literature and what we could find online, that community health workers address barriers to care, or barriers to accessing the healthcare system. And they're focused more on reduction of kind of general health disparities at a community level. Whereas non-clinically licensed patient navigators address structural, cultural, social, emotional, and administrative barriers to care. And they're focused on reduction of cancer health disparities in medically underserved patients and timely access to care across the continuum. And the clinically licensed patient navigators are more focused on addressing the clinical and service delivery barriers to care. So it's definitely more clinical. And they're focused on provision of services to at-risk populations, which may be defined by individual need, high acuity, or high volume at the institutional level. So I'm not going to go through all of these, but I'll just show you one more example. So this one is for patient empowerment, which we've defined. So again, the consistent definition across three is that they all identify problems and resources to help patients solve problems and be part of the decision-making process. And we wanted to point out that an important facilitator of patient empowerment is development of good patient rapport. So for the community health worker, they focus more on motivating the individual and communities to make positive changes in health behaviors. They activate and empower individuals and communities to self-advocate and make healthy decisions, whereas the oncology non-clinically licensed navigator assist patients with addressing the different issues that I've mentioned and helping them participate in decision making and identifying solutions. They empower patients to know their options and educate patients on their rights and preferences. So in terms of the clinical role, one is specific to nurses and one is specific to social workers, but nurses assist in decision making regarding diagnostic testing and treatment options. So that's very clearly not something a non-clinically licensed person should be doing. And then social workers provide patients with strategies to cope with the disease, treatment, and stress. So again, it's specific to social workers. So we created this framework, and I have copies of it in case anybody wants to see some after the presentation. And we thought it was important to go back to patient navigators to figure out what we missed, where there's gaps, and what they're dealing with day to day. So we conducted virtual focus groups through, we used Adobe Connect, so we used a webinar service with patient navigators across the country. And the goal was to identify the most important roles and responsibilities for each domain, and then also identify knowledge, skills, and abilities that are most critical to help us build some competency statements. We also asked them some questions about, to try to get some feedback related to the training that we're developing. So I can't include the data because it's so hot off the press. I want to make sure that it's accurate, but we held 6 focus groups with 21 navigators. They were largely female, which is not surprising. Most of the navigators we work with are female. They tended to be either older or younger, so there were a lot in the 55 to 64 and the 25 to 34. They were mostly white and or non-Hispanic Latino. They tended to be very educated. They held either bachelor's or master's degrees for the most part. They had varying years of experience from less than 1 year to more than 10. They worked in different types of settings and in community organizations as well. We had 3 from Georgia, 3 from Hawaii, and 4 from the DC area. So there were obviously other navigators from other areas, but those were the largest proportion. So the things that came out of the focus groups were pretty similar to the things that we found in the literature and the things that we identified through our consensus process. So the main things that they identified that navigators were doing were related to assessing patients, educating them and advising them, referring patients to resources, guiding patients through the cancer continuum, eliminating barriers, helping to coordinate care, advocating on behalf of patients and helping to empower them to participate in the decision-making process, providing culturally sensitive support, and engaging community stakeholders. So they aligned pretty well. And at this process, or at this point in the process, what we're trying to do is map that back onto the framework that we developed so that we can create a more robust framework. So to get to the competencies, we really want to make sure that we are in alignment with the Association of American Medical Colleges. So they did some research that was published last year looking at domains for training or for competencies for healthcare professionals. And they identified 8 common domains where there was overlap and recommended that these be used as a framework for developing competencies. And I'll show you those domains in one of the next slides. We also wanted to make sure that we were aligning with the Oncology Nursing Society. So they had done some work about a year before we started on developing competencies for nurse navigators. So we wanted to make sure that they were aligned and that we weren't duplicating anything and that we were taking that into consideration. So our focus was on non-clinically licensed patient navigators. So the next step, once we align all of these things together, we'll develop competency statements, and then we'll conduct a national survey of patient navigators and their supervisors to validate those competencies. So we're working with Dr. Maslink, who's going to help us with the survey and with the analysis for that. So we're hoping to roll that out soon, by the end of the month or early June. So these are the domains that I mentioned. So the ones on the left are the AAMC domains. The ones on the right are just based on the first part of our research. So these were the 12 boxes of domains that I showed you earlier. So there are some gaps, but at this point we're going back through what the navigators told us in the focus groups and filling this in. Because to us, again, it's really important that we're aligning our work with an existing framework that's been established for healthcare professionals. It's also worth mentioning the state role, and I mentioned this earlier in terms of community health workers. There are a lot of parallels. So community health workers in several states have been successful in establishing the profession of community health workers. They've created a credentialing process, and in some states there are reimbursement mechanisms for community health workers. So we're trying to follow this similar process, but recognizing that patient navigation is different and the successes that they had might not work in patient navigation. And for anybody who was here, I think it was January, one of the presentations on community health workers, one of the things the speaker talked about was how the states have done a lot of work, but nationally it's very difficult to get all of the states on the same page. And so we're trying to learn from that experience and trying to figure out how we can create some coordination, but recognizing that states need to have the flexibility to do what they need to do. So through our cooperative agreement from the CDC, we want to create a guide for comprehensive cancer control programs. So we'll have our training, and this would be like an accompanying guide that would help the states leverage the free training and create maybe an in-person training of their own, because there are some components that are much better in person. We want to provide them some tips for providing technical assistance to navigator networks. So I mentioned CPNN here in DC. There are lots of navigator networks in different states, and we've done some research to identify some successes and some challenges with those networks. So we want to distill that information and send it out to the states. And then we also are thinking of including some kind of policy piece to help states work at the state level to advance the field of patient navigation. So that likely won't happen until much later on this year after we've launched our training. So I just wanted to acknowledge the steering committee. Again, we had great representation from a lot of different groups and included several patient navigators and community health workers. And then I wanted to acknowledge our funders. So Pfizer Global Health Partnership Program funded our original live trainings through CA-SNAP. The Avon Foundation for Women partially supported the development of our framework and our competencies. And I mentioned that the CDC funds our current development for the online training and for the toolkit.